We're going to give you a presentation this morning on GEM21. What is it? It consists of purified recombinant platelet-derived growth factor in a sterile physiologic solution, plus an osteoconductive bone graft, the beta-tricalcium phosphate. Why these two specific components? Because it takes advantage of the concept of paradigm of tissue engineering, which was introduced by Dr. Lynch over 20 years ago, by combining growth factors such as the PDGF that you see highlighted in yellow with your scaffolding materials, be it osteoconductive scaffolding materials like the beta-TCP or allografts or xenografts, or tissue engineering can also be applied to soft tissue and gingival recession type defects by combining the growth promoting signaling molecules with a soft tissue type of graft material. So again, signaling molecules, i.e. growth factors, i.e. PDGF, in combination with scaffolding materials. And those two things then act to recruit the cells, which are the third leg of the stool of the tissue engineering triad. And of course, the cells that we want are our stem cells, which can differentiate into all kinds of healing cells, such as osteoprogenitor cells, osteoblasts, or fibroblasts, or periodontal ligament cells. So really to optimize regeneration, it takes all three components: signals, scaffolds, and cells. And that was the whole concept, the whole paradigm behind the development of GEM21S. Okay, so again, the signaling molecule in GEM21, of course, is purified recombinant PDGF. And PDGF, platelet-derived growth factor, is the body's most important healing molecule. That's why we chose it as the signaling molecule in GEM21. Everybody, all of us, have PDGF in our blood as we're sitting here this morning. It's naturally found in our blood platelets, right? And it's very important in stimulating all the events of wound healing and bone regeneration. It does that by recruiting stem cells. I'm going to show you a couple of videos this morning to demonstrate how potent PDGF is in recruiting the healing mesenchymal stem cells to your wound. It also acts to recruit other types of cells, like the osteoprogenitor cells and the other kinds of angiogenic type cells. It causes those cells to proliferate, so you got more of the cells there to do their work, which is, i.e., cause regeneration of the tissues like the bone or the soft tissues. And very important as well is it stimulates angiogenesis, because you can bring in all the cells that you want, but if you don't have an adequate blood supply, those cells are not going to remain viable, right? So you need to have a blood supply, you need to recruit new blood vessels into the site of the wound, into the bone defect, in order for the cells to be able to live, to be viable, to do their work. And so PDGF, it turns out, does that as well, recruits new blood vessels into the site of injury. So again, PDGF occurs in platelets. Once those platelets, but it's inside the granules, what's called the alpha granules of the blood platelets. Once those platelets, though, become exposed to what's called the subendothelial lining. So if you remember, blood vessels are lined by endothelium, right? So when they're lined by the endothelium and that tube is all intact, the platelets remain quiescent. But as soon as you have an injury, a cut, or any sort of an injury that causes bleeding, causes rupture of that endothelial lining of the blood vessel and therefore bleeding, it exposes the platelets in the blood to the subendothelial tissue, right? And during the bleeding process, and there are molecules in that subendothelial tissue then that activate the platelets. Once those platelets are activated, they release their contents, including platelet-derived growth factor. There's a couple of different ways to look at this that we've published on, but the activity of PDGF. But the most important thing is to know is that, again, PDGF is a very broad spectrum catalyst of regeneration, of healing, right? It has the broadest biological activity of any FDA approved biologic in the healing cascade. It's supported by multiple randomized controlled clinical trials in multiple indications. And we're going to go into, each of those, many of those anyway, studies and clinical trials. And again, here it just talks about, again, how the mechanism of action. And I think that's really important, right? Compared to other biologics that are available in dentistry, like matrix derivative, for example, that's been available also for 20 years. We still don't really understand exactly the mechanism of action of it. PDGF is very well known. It is probably the most well-studied biologic in dentistry, and frankly, one of the most well-studied regenerative molecules in all of medicine. This is from a publication by Dr. Arne Kaplan, talking about the exact role of PDGF in bone formation and how it works, which is really, again, just chemo-attracting the osteoprogenitor cells, the healing stem cells, fibroblasts, promoting the blood supply, and all of that, leads to regeneration. I've heard that, a lot of people think more of PDGF as a soft tissue molecule. It certainly promotes soft tissue healing, but it also is FDA approved for bone regeneration based on many randomized controlled clinical trials. This shows how in what phases of bone regeneration PDGF acts. Here we just see the kind of the different stages of bone regeneration, starting with the hematoma, the blood clot, following bone injury, inflammation, granulation tissue, then a callus, soft callus forms. That soft callus then matures into a hard callus, which then goes on to remodel into good quality dense bone. PDGF acts in that bone healing cascade all the way from immediately following injury or following, for example, placement of a bone graft into a bone defect. So all the way from day one through about the first 6 weeks, that is where PDGF has the most important functions. After that, really, and again, it works by chemotaxis, mitogenesis, and angiogenesis. After the first 6 weeks, the bone healing cascade is pretty well defined. And at that point, then it really is just a maturation from your woven bone into your more dense lamellar bone. Okay. So what we did many years ago was to say, well, PDGF does occur naturally in the blood, but there's some problems with that. And we're going to talk a lot about this again in the next few slides. Just to try to concentrate PDGF from the blood, like you do with making platelet-rich plasma or PRF, platelet-rich fibrin, right? The very patients that need the healing boost the most are the ones that have the lowest natural occurring levels of PDGF. So it's well published that diabetic patients, for example, who we all know, right, are poor bone formers, poor healers in general, they have lower levels of PDGF in their blood, right? So why would we think that just trying to get PDGF from platelet-rich plasma or PRF, right, would work in those patients that have compromised healing, right? It's an oxymoron. It makes no sense. So we realized that, and it's been known, and PRP again has been around for 30 years. it's always been controversial. It's really never had good randomized controlled clinical trials that are positive and very supportive of it. And so what we did many, many years ago is we said, okay, we need a consistent supply of PDGF. PDGF works. We know it works. We know exactly how it works. We just need to make sure that it's consistent every time from lot to lot to lot. And so we took the gene, we isolated the sequence, the amino acid sequence of PDGF. Based on the amino acid sequence of PDGF, we found the gene that encodes for that sequence. We took that gene out of a human cell and put it into a yeast cell. And then you can grow up the yeast cell just like you're kind of brewing beer. And the yeast then in this big vat expresses the PDGF, makes the PDGF molecule because you put the human gene for the PDGF into those cells. And then, so it makes the human PDGF, and then you can just, purify out the PDGF out of the broth, out of the beer, so to speak. And you've got a pure, sterile, synthetic protein that is consistent every time. And as we're going to talk about, the way we make GEM21, it's 10,000 times the concentration that you can find in PRF. Okay, so let's talk about comparison to other biologics, right? So this is a graph that looks at how effective is PDGF at promoting the growth of bone-forming cells, of osteoblasts, and also of PDL cells and mesenchymal stem cells. So this graph looks specifically at osteoblast type cells, right? And the PDGF stimulated cells are in the blue bars there. And you can clearly see that PDGF is the most potent mitogen of all the biologics, including BMPs, for promoting the growth of bone-forming cells. How about chemotaxis? How about the recruitment, the cell homing, bringing those bone-forming cells into your bone graft? How does PDGF compare in that test? Well, here you see other growth factors, the TGFs, the FGFs, which you hear some about in dentistry. Of course, BMP2, BMP4, which is infused, and OP1, and then PDGF. And you can again see PDGF is the most potent inducer of chemotaxis among all of these different growth factors, right? And why is that important? Because chemotaxis is what brings in the bone-forming cells into your bone graft. Okay, and this is a video that illustrates how potent PDGF is in attracting the healing stem cells. So the shadow here is a needle tip that's expressing recombinant PDGF from that needle tip, and these cells are fluorescent labeled stem cells, and you can see the stem cells migrating towards the tip of that needle that's expressing the recombinant PDGF. It's an incredible visual testimony to how potent PDGF is at attracting the healing stem cells into your treatment, into your bone graft. Okay, now, how does recombinant PDGF, GEM21, how does that compare to PRF and PRP, which we hear a lot about? And I think it's really quite interesting, right, that you've got a lot of people out there on the lecture circuit, right, talking about growth factors, and then they sort of switch over to talk about PRF or PRP, right? Like trying to make the connection that PRF or PRP is good because it has growth factors in it, right? That's sort of their whole thing. So great, that's great, right? We love the fact that they clearly acknowledge that the reason why PRF or PRP is so good is because it has growth factors in it. So they're clearly suggesting that growth factors are great and they're these great healing things. But how much of the growth factors do they really have, right? And we're gonna look at that. But before we go there, I do want to say that, I do think that PRF in particular, is certainly not all bad. I think it certainly has a role in the sense that it does improve the healing of your particulate bone graft. So it keeps the particles of your bone graft from sort of migrating away from the bone graft site. It creates what's called sticky bone. And I think this is a good thing. I am a firm believer that one of our biggest challenges in dental surgery to get regeneration is micro movement of our bone graft. So if you can minimize the micro movement of the bone graft, because the micro movement shears off these fragile little capillaries as they start growing into your bone graft, right? And that's a bad thing because we all know if you get hypoxia in your graft, what happens? You're not going to get bone formation. You get scar tissue, because you get scar tissue anytime you have a site of hypoxia. You obviously don't want scar tissue formation in our bone grafts. We want bone to form in our bone grafts. You need a oxygen-rich environment for bone to form. So if we can minimize the micro movement in our grafts, make sure those capillaries don't get sheared off as they're growing into our grafts, that's great. So that's a good thing. PRF, PRP has also been reported to facilitate some soft tissue healing. Again, just like in bone, that's very controversial. It's certainly never been FDA approved for promoting soft tissue healing. And an important point is that neither PRP nor PRF is an FDA approved biologic, right? So you're using something that is not FDA approved for any application when you're using PRP or PRF. Randomized controlled clinical trials on PRF and PRP are very controversial. Whether or not it does anything, or maybe it does something negative to your bone graft, right? That is, we don't know, because the clinical studies are all over the place. And again, none of those clinical studies have been audited by FDA. So it also is possible, frankly, people can cherry pick their data, right? They can try to get statistics to show anything that you want them to show. And that's happens, as we know, especially when we don't have FDA audited clinical studies. So it's just really controversial. Most studies show that PRF or PRP has no beneficial effect on bone regeneration. And I'll say that again. Most clinical studies, the majority, show that PRF and PRP has no beneficial effect on bone formation. So it may improve, the handling of your graft. As a clinician, you may feel better about that. Totally get that. Makes sense. Understand it. But, and it may maybe help you with some soft tissue healing. But compared to GEM 21, which has hundreds, right, of studies showing a beneficial effect on bone regeneration and soft tissue healing, the data is very, very mixed and controversial on PRP and PRF. One of the reasons for that may be the fact that in addition to the good things like the growth factors and PDGF that's in PRP and PRF, there's also some bad things in it. Platelets contain many, probably hundreds of different kinds of proteins. And one of the other proteins in PRP and PRF is called DKK1. That's a protein that actually inhibits bone formation. There are some of the major biotech companies in the world, like Amgen, that have actually tried to develop antibodies to DKK1 to inhibit DKK1, not concentrate it, but actually inhibit it as a treatment for osteoporosis. So there's a lot of stuff, right, in PRP and PRF. There's also just some practical considerations to keep in mind with PRP and PRF. You have to draw blood, of course, to get it, and that could be a hassle for your office staff. If your office staff is not used to drawing blood, patients are nervous coming into the dental office for dental surgical procedures. They're already nervous. And now you're drawing blood, which a lot of patients don't like. Just even going to the Red Cross and donating blood, let alone, oh, I'm going to have dental surgery and now you're going to poke me in the arm as well and draw more blood. Again, any amount of PDGF, especially and of other growth factors in PRP and PRF, are there at extremely low concentrations. And we're going to, again, show another couple of slides about that. But we've already talked about the fact that this is especially true in older patients or diabetic patients or smokers. The very patients that need healing, a healing boost the most are the ones that have the lowest levels of PDGF in their platelets. Many insurance companies won't cover PRP or PRF for any medical applications. And there's, again, good reasons for that. The recombinant PDGF has none of those drawbacks, right? It is produced in a consistent concentration. It's sterile. It's right off the shelf. You don't have to draw blood, spinning, and so forth. So now what's the data to support what I just said? And specifically to support this fact that the growth factors that you hear lecturers talking about, there's all these growth factors in PRF and PRP, right? And they do that because they think that's a good thing. But the fact is that the level of those growth factors, as we've talked about now, is minuscule, is at a sub-therapeutic level. Now, this is from a publication a few years ago by a big group in PRF. Right, Dr. Myron, especially Richard Myron, right? It's kind of, he's got books, right, on PRF. So one of his publications showed, oh, look, we have all of these different, growth factors here. And this particular table looks at the level of different forms of PDGF in PRF and PRP. So he actually looked at PRP with the regular version of PRF and then what's called an advanced PRF. Now let's just focus, here on this figure F, because this side has the cumulative release. Over here, you look at, levels of PDGF at a particular time point, 15 minutes, 60 minutes, et cetera. But here is the cumulative. So the total amount of PDGF, all isoforms of it that are released over the first 10 days. And he shows, the regular PRF and the activated or advanced PRF and then PRP. And it looks like, oh, this is good. There's growth factors here, right? But now look at the scale. It is picograms per milliliter. Picograms per milliliter. The concentration, the lowest concentration of PDGF that has ever been demonstrated to be therapeutic is thousands of times higher than that. So here's another table from that same publication. We all know, right? Remember that PDGF BB is the most active isoform of PDGF. So let's focus on that one. We could look at any of them, but because PDGF BB is the most active, let's do that. And that, of course, is what is in Gem 21, right? So PRP, PRF, and it's advanced PRF. Ooh, that sounds great. That's 1,000 picograms. So do you remember your chemistry, right? Or your introductory biology classes? What is 1,000 picograms? Wow, that sounds like a lot. It's just 1,000 picograms. Wow. 1,000 picograms is 1 nanogram. 1 nanogram. 1 billionth of a gram. Okay, so 1 nanogram in a petri dish. In a petri dish in a laboratory, 1 nanogram per mil is not enough to even stimulate, some cells in a petri dish, let alone to put it in a big bone defect in a patient that's bleeding and perfusing, and you know, it's not gonna do anything. Let's put that on a scale and compare it to GEM 21. So PRF, or it could be PRP, advanced PRF, advanced. 1 nanogram, I've actually blown this up by, you know, kind of an order of magnitude or two, just so you can kind of see where it would be, right? Compared to GEM 21. Now, why is GEM 21 graph so tall? Because GEM 21, right, is tested every lot to make sure it has a concentration of 0.3 milligrams per mil. Again, remember your introductory biology and your chemistry, right? 0.3 milligrams is 300 micrograms per mil. 300 micrograms per mil is the same as 300,000 nanograms per mil. So now you've got 1 nanogram per mil in PRF and PRP. 1 versus 300,000 nanograms per mil for GEM 21. Now, tell me which is the most potent. All kinds of studies have shown this. This is one study that was published recently comparing PRF to recombinant PDGF in a bisphosphonate-related osteonecrosis of the jaw model in rats. And it just shows that actually if you add the recombinant PDGF to PRF, right, you can significantly increase by about twofold the healing of these bisphosphonate-related lesions within, I think that's within 4 weeks or so. I could double check that. But again, the bone defects that were healed, only a third, well, less than a third with the PRF versus 80% with the PRF plus the recombinant PDGF. Okay. This is another video in which we have looked at the mechanism of action of GEM 21, of recombinant PDGF, mixed with your bone grafts. So what you're going to see here is a bone graft hydrated with saline, and looking at the ingrowth, the chemotaxis, the ingrowth of the mesenchymal stem cells, the healing stem cells into that bone graft, right, by itself, or with imdogain, enamel matrix derivative, or with GEM 21. GEM 21 being the only pure sterile off-the-shelf product that contains recombinant PDGF. So I am going to hopefully be able to pause this for a second. Let me back up. Here we go. And PDGF, GEM 21, the only growth factor shown to promote both bone and soft tissue. Okay, so now I'm going to pause this again because I want to explain it a little bit. So what we did here is we put bone graft on what is your right of the culture dish, and we put stem cells, mesenchymal stem cells, the healing stem cells on the left 2 millimeters away, right? And then we did just the bone graft by itself, hydrated with saline, or bone graft plus the enamel matrix derivative, or bone graft hydrated with GEM21S. And we filmed over 72 hours to look at the migration of the healing stem cells into the graft. And already you can see very quickly, right here, we're just a little ways into it, that all of these stem cells have now already migrated, within the first day or so, over way towards your graft when it's hydrated with GEM21. When it's just hydrated with saline, you just got a few stem cells sort of meandering, wandering around. And when it's actually hydrated with the enamel matrix derivative, there actually are fewer cells that are migrating into your graft. So it actually is somewhat inhibitory, probably as a result of the enamel matrix derivative having a hydrophobic gel carrier. Okay, so here it is. So we'll watch it all the way through this time. Right. So look at all of these stem cells. They proliferated. There's a whole bunch of them now. And they're going crazy, right? They're migrating like a racehorse over into your bone graft, compared to just your graft alone. That's why you want to use GEM21. That is the whole mechanism of action captured in 10 seconds for GEM21. The more of those healing stem cells you have, they'll differentiate into your osteoprogenitor cells, which differentiate into your bone forming cells, your osteoblasts, right? Which would you rather have? A graft treated with GEM21 that has thousands of stem cells in it, going and differentiating into bone forming cells, or the ones that maybe have, 10 or 20, or the ones that maybe have almost none? Okay. The clinical literature supports what I've just told you, right, about enamel matrix derivative in stem cells being actually not improving, let's just say that, not improving your bone graft. This is a publication from the Journal of Periodontology, one of our best, journals, the Journal of the American Academy of Periodontology, from a very well-known group in San Antonio, from the Department of Periodontics in San Antonio. Conclusion was the addition of Imdogain to allograft provided no statistically significant improvement in either soft tissue or hard tissue parameters measured compared to the allograft alone. And now we know why. Because we just saw it with the stem cells. Right then, I hate that stuff. So, it's no wonder. Now, this study was a clinical study in patients, was published, certainly well before, we did the videos and looked at the effects of Imdogain on stem cells, but it perfectly correlates. And it really, our videos and our cell research just underscores why clinically they found no beneficial effect when you mix on either soft tissue or hard tissue with Imdogain when you mix it with allograft. Okay, in contrast with recombinant PDGF, the recent systematic review by a group out of the University of Michigan has shown that the addition of PDGF to your bone grafts safe and effective and provides consistently positive outcomes. They looked at a very rigorous methodology following the PRISMA systematic review guidelines. They identified over 500 publications on recombinant PDGF in dentistry. Okay, this is not orthopedics. It's not soft tissue wound healing. I'm not including those. If you added those, it'd probably be thousands. Right, that's the volume of literature that you have supporting PDGF and wound healing and bone regeneration application. But just in dentistry and craniofacial applications, there were 500 publications. They eliminated all the animal and preclinical studies, and they found 64 publications of clinical studies on PDGF. 1,600 defects were treated in the studies, about a 1-year follow-up. And again, PDGF is very safe, no adverse reactions. In fact, again, PDGF promotes healing, so your patients are going to heal better and faster when you add PDGF to your treatment. And it was found to be consistently positive in improving the results of your therapy. So let's take a look at some of these publications, some of the research that has been done specifically with GEM21. This was from our randomized controlled clinical study. Publications based on this study actually have received the very prestigious Earl Robinson Award from the American Academy of Perinatology, not once, but twice, 2 different years. This is it's an award given to the highest impact or best publication of a clinical study on a regenerative product. GEM21 has won this award twice, or the papers published on the GEM21 studies have won twice. So hopefully that explains the mechanism of action and why GEM21 is so much better at promoting healing and promoting bone growth, bone fill, promoting positive clinical outcomes than PRF, PRP, Amdogain, et cetera, right? So now let's look at some clinical results. This is a study that I did with Dr. Nevins many years ago, in which we looked at recombinant PDGF with demineralized bone allograft. And you can see the calculus on the root surfaces here. These roots were notched. Then we took a round burr and put a little notch into the root surfaces at the apical extent of the calculus, which is very important. Means that everything coronal to above that notch was infected, was contaminated. And then we took biopsies of these patients and then reconstructed them with implants. And here you see a tooth root surface here, right? And this is the notch that I talked about that was placed in the bottom of the calculus. So everything above this was covered with that nasty calculus, right? And now you have regeneration of the entire tooth socket. Regeneration of it's called the cementum, which is the outer layer of the tooth root. The periodontal ligament, which is the fine little connective tissue ligament that connects the cementum to the new bone, and millimeters worth of new bone growth. And that occurred not only in the intrabony periodontal defects, but also in the furcations between the roots of the teeth. And here's the notch and complete fill. It's 100% regeneration in that case. On the right, you see from a different study that we did, but you see the same type of phenomenon, the same type of healing around implants, in the sense that, you know, we created these big defects. I'm going to show this study a little bit later, but big bone defects around these implants. And then, you know, one group was treated with the recombinant PDGF and a bone graft material. And this is about 4 to 5 millimeters of vertical bone growth up the implants with PDGF. Here's another study, similar study to what I showed before. This is a case from our randomized controlled clinical trial. Here, you know, you can see this is a pre-op photo, post-op clinical photo. Here's the pre-op radiograph. So this is the bone defect here with a little bit of a involvement of the furcation of that tooth root. So that dark shadowy area there, and this dark shadowy area here are the bone defects. You can see that up here in the clinical photo, that the bone defect corresponds to what you're seeing there. That bone defect corresponds to what you see there. And then within 24 months, you have complete fill of that defect and a fill mostly of this defect, and then by 36 months, it's perfect. 100% fill radiographically. Here's another case treated with the GEM 21. This was like a huge defect, like a 15 millimeter deep defect. Here you can see the soft tissue's been reflected. This is the bone defect right there. And now here are the radiographs that correspond to that case. You can see again the huge defect here, right? And then within 3 months and 6 months, you can already see that defect filling in within 6 months, 12 months, 18 months, 24 months. So again, out here, basically certainly by 18 and 24 months, you have 100% fill radiographically of that defect. Another case, very similar. On the left is the clinical photo, huge bone defect here. Again, this is an intrabony bone defect. It's kind of going inside the bone. You can see that on the X-ray on the right. And then here is the 6-month appearance and the 12-month appearance. Again, complete fill with of the defect with new bone. There's another case. Now this was using the recombinant PDGF with a different carrier material. So technically it would be off-label. This was using the PDGF with allograft. But again, huge bone defect here. Again, an intrabony bone defect almost down to the apex of that tooth root, all the way through to the facial aspect. You lost the facial buccal plate of bone, treated with recombinant PDGF with an allograft, and complete fill of that defect in 8 months. Another case of the recombinant PDGF, again, with an allograft, so this would be off-label. But many clinicians report good results with that mixture, but we certainly can't promote it that way. But you can see again in eight months complete fill with perfect looking bone in those cases. This is a very interesting case that was just recently reported by Dr. Urban, just reported in June, a couple months ago. And what you see here on the pre-op side is a very severe periodontal defect that kind of is continuous with a residual defect left over from an extraction socket. So periodontal defect continuous with a defect from an extraction socket where they had removed a tooth or an implant there. Treated with the GEM 21 and a membrane was used over this. And you can see at 8 months, the reentry photo as the clinician, Dr. Urban, went back in to place the implant in, and you had a beautiful, beautiful bone fill, bone regeneration, all the way up that root surface, right? And of course, fill of the socket as well. And the implant was placed into that bone. Okay, so that so far we focused on PDGF on promoting bone healing, right, and bone regeneration. Just a couple of cases here also to talk about for using it to treat gingival recession associated with periodontal disease, which is totally on label. This was a case or a publication, a study by Drs. McGuire and Shire, where they compared the use of PDGF plus the beta TCP in this case to the gold standard, which is a subepithelial connective tissue graft. And you see the connective tissue graft on the left and the GEM 21 plus the collagen tape was used over the GEM 21 in these recession cases. So this is baseline. And I'm going to just flip through these. Whoops, I'm going to flip through them fairly quickly, but not that quickly. Here's an intraoperative photo during the surgery. So you have about an equal amount of recession. Now, keep in mind that to treat this case on the left with autograft, you got to go to the palate, to the roof of the mouth. You got to cut out a piece of connective tissue off the palate of that patient and use it. Of course, with GEM 21, you don't have to do that. So in orthopedics, we talk about, hey, you get this, the same benefit with GEM 21 or with augment in orthopedics, without all the comorbidities that would come from having to harvest your autograft. This is exactly the same paradigm here. You want as good an outcome as you get with the gold standard with your autograft, but without those comorbidities of having to, cut a piece of tissue off the palate, right? And this is the results then of the studies of this case at 6 months. So comparable result. Okay, but maybe even more important or compelling than the clinical result is the histologic result, because with the quote gold standard of the connective tissue graft off the palate, you just got what's called a long junctional epithelium. You got a kind of a scar tissue adhesion to the root surface. But with the use of GEM 21, you got complete regeneration of the entire socket around the tooth. The bone, the periodontal ligament, and the cementum. So it turned out that not only were the clinical results comparable, but actually the histologic results showed that the GEM 21 treatment was actually superior to the gold standard. Okay, so that just about wraps this up. Just a few couple summary slides here talking about the optimum, ways to use GEM 21, some of the tips to optimize your clinical results. Take the GEM 21, it has to be stored in the refrigerator. So take it out of the refrigerator when your patient comes and then add it to your bone graft for at least 10 minutes prior to use. If it's 15 or 20 minutes, it's perfectly fine. It could even be 30 minutes. It might dry out a little bit in that period of time, but it's not going to hurt the protein. But at least add your PDGF solution to your bone graft and let that sit on the back of your surgical tray for at least 10 minutes before implanting it into the patient. If you can, it's best to use a flapless surgical technique, especially in the maxillary anterior. It just helps to maintain your aesthetics a little bit better. And one of the beauties about GEM 21 is, in many cases, you do not have to use a membrane for guided tissue regeneration, right? So therefore, there's no need to have to reflect a big soft tissue flap if you can access the defect without doing that. But regardless of how you do your surgical technique, it is critically important to get rid of all the granulation tissue from the bone defect. So let me say that again. It is critically important to a successful outcome with GEM 21 to remove all the granulation tissue from the bone defect before you place the GEM 21 graft. Personally, I like to do root conditioning, but with like an EDTA or citric acid or tetracycline, that's somewhat controversial. Some people like to do that, some people don't. I think it helps to remove what's called the smear layer on the root surface, but others, report good results with just doing scaling and root plane. So again, it's important to thoroughly debride and degranulate the bone defects. You can use magnification loops to help you do that. Any kind of instrumentation that you think would be necessary, from curettes to a lot of irrigation, so you can then once you get rid of all the granulation tissue, your graft is soaked for at least 10 or 15 minutes in the GEM21 solution, the recombinant PDGF solution. Condense that graft into the bone defect fairly firmly. You're not going to crush it, but condense it, firmly into the graft if you can, especially if you have a space maintaining, infrabony type of defect. You can do a fairly firm, condensing of the graft into the defect, but do it sequentially, right? You're not going to dump all the graft into the defect at one time. You're going to do it somewhat like you would have done an amalgam in past years, where you just add it in layers. You can use a membrane with GEM21. Again, we do not recommend it if you have a space maintaining defect. So if you have an interbony type of defect, so you have bony walls around the bone defect, I would just suggest using just the GEM21. But if you have a non-space maintaining defect and you don't have enough bone walls to contain your graft, then of course you do need to have a membrane, because you have to contain your graft somehow and prevent that micro movement that I talked about before. So stabilizing and containing the graft is very important. Protecting the graft from the oral environment. Try to get primary closure to the extent you can. And if you can't, again, a membrane can help separate that oral environment, the saliva and the bacteria in the mouth, from your bone graft. And of course, you may need a bone graft or a membrane if your defect is not space maintaining. If you do choose to use a membrane, use either a collagen membrane or a PTFE membrane. Do not use one of these PLGA, polylactic polyglycolic acid membranes, because they'll create an acidic environment when they resorb. That last bullet was just, sometimes we'll do a dental appliance over the grafted site, right? Just because you might need a prosthetic tooth there for aesthetic reasons. If you do that, you want to make sure that that is not pushing down on your bone graft, because that will also cause movement of your graft. Okay, so the take-home message is here. GEM21 is the only FDA-approved product in dentistry that has been proven in randomized controlled clinical trials to stimulate the healing of both the bone and the soft tissue. And it's been FDA approved not only in dentistry, but as opposed to like enamel matrix derivative, which is only approved in dentistry, GEM21 is also approved for orthopedic bone grafting and for dermal soft tissue healing. Its mechanism of action is very well established, as we've reviewed. It is a very potent biologic agent, much more so than what you have with PRF or PRP or Endogain. There's a long history of safety. There's about 5 million patients now altogether that have been treated with recombinant PDGF, all very safely. It promotes excellent soft tissue healing as opposed to something like infused recombinant BMP, which elicits a lot of swelling post-op. With GEM21, you get excellent post-op healing. It improves your bone regeneration, and it also, interestingly enough, accelerates the remodeling of the graft material, leading to faster replacement of the bone graft with the patient's own bone. And after all, that's what you want, right? You don't want to go in and place an implant, or you don't want to have a site that has a lot of graft material a year down the road. You want all that graft material replaced with the patient's own bone, and GEM21 helps that happen. All right, and I think that concludes the presentation for this morning, and I'd be happy to answer any questions.